Hey guys, Marshall with PhysioU, and I'm here at the teaching table today. And again, I have two PT students, Cam and Chris. Thanks for joining me, guys. And today we're talking about the objective. How do we organize the chaos? All right, so big picture, right? Objective, kind of like we did with subjective. The idea is we're trying to be able to answer a couple of key questions by the end of it. Right? Can we answer what their diagnosis is, right? Can we, to our best guess, have a medical pathoanatomical tissue source, right? If I was going to inject something, what would that source be, right? We try. We want to identify any movement faults that they have, like what's causing that tissue source to be painful. Often, it could just be a macro trauma, right? I sprained my ankle, right? It wasn't that they moved wrong, or then maybe they just stepped in a hole, right? Versus the guy that just kind of insidiously got ankle pain, slowly progressed over the course of 3 months. Right? I want to identify, well, what might have been driving that tissue to become irritated, right? Third, what impairments, right? Impairments are different. Impairments are like the thing we actually treat, whether it's balance or strength or mobility, right? What are those key components that lead to a fault, that lead to a diagnosis? So kind of think of it like an onion, where big picture, your diagnosis, ankle sprain, or let's use a different one. Let's use patellar tendonitis, right? The movement fault, well, maybe his knees keep translating forward way too much, right? The impairment, right? Maybe he doesn't have enough glute strength. Maybe he doesn't have the coordination to do a good hip hinge, right? Maybe he lacks dorsiflexion and he goes up on his toes too soon, right? All those add stresses to the knee. So we have kind of this hierarchy, but you should be able to try to answer all those, right? And the idea is your tests should mimic that, right? We have tests for diagnoses, right? We kind of call those, a lot of those are provocative tests, things that bring on their pain. We have tests for movement faults. Most of those are watch how they move. There's lots of different ones based on which region. And then if it is painful, can we correct it? So if they show us that squat and their knees are going way far forward, can I have them bring their knees further back, and does that change their pain? And then we also have our impairment tests. So looking at mobility. So prone, does their knee get to their butt? Quad strength, seated at the edge of the table. So we have different ways to test them. And our job, your guys' job, is to be able to kind of keep that all clean in your mind, to organize it. Right? And lastly, at the end, we're gathering this information for what reason? To be able to help the patient. We want to be able to help the patient, right? Cool. So with that being said, let's take our students that have kind of been in the clinic, and what are some questions or what are some difficult situations you guys have had based on your objective exam?
I think, first, just going out to our first clinical rotation, we just learned all these tests in ortho, and we get that first patient, say a knee patient, and we have our 3 hypotheses, but we kind of go through all of our tests and trying to get that that best diagnosis of what we think is going on. But at the end of the day, you look at some of the other therapists and they're doing 1 or 2 tests, very specific. So how many tests is basically too many? Or how should we kind of prioritize our tests?
Good question, right? And there is no exact answer, right, that says, oh, you should have this many positive tests. Mm-hmm. There are some cases where it is, like if you think of like the SIJ with Laszlo cluster, there's research that shows, oh, you should have, right, your first 2 tests should be positive, if not do a 3rd. So there are some things, but majority of the time, it's really what you may think you need to have a positive, right, is totally different than your next therapist or student. So I think the important thing is in the clinic, or in the classroom, you kind of learn like, hey, this test is for this pathology, right? McMurray's for meniscus, Thessley's for meniscus, right? And if it's negative, it doesn't hurt. If it hurts, it's positive, right? When you get to the clinic and someone has knee pain, half of these tests hurt everybody, right? It's like, oh, you have a meniscus problem. Well, every test you do hurts. So it's like, well, do they have all 3 of these diagnoses? No, it's probably not the case. So then we say, well, let me just keep testing, and we look for that dangling carrot. We look for that one test that we kind of all of a sudden hang our hat on, right? And that's kind of incorrect as well, right? I have students in the clinic now where they'll do all these tests that are negative, 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 but in the subjective, they said that one thing, right? It hurts when I sit and go to the movies, and they're so fixated on moviegoer sign, but every test was negative for it, and they hang it. So I think that works also with objective, where you look for that one test and hang your hat. So to answer you, right, idea is there is no exact number. The idea is what makes you confident enough to treat them.
Yeah.
right? So if you've done 2 and you say, you know what, this looks like it's this, right? I don't have any competing things that would change what I'm gonna do today. I have enough tests. And so if I realize, hey, this guy squatted poorly, I fixed it, got better. He had good strength of his quads, but he had really bad range, right? Okay, I think I'm enough. So I have enough to confidently treat is like what I would say. And that's different for everybody.
I think I have a funny story about performing too many tests. So my very first patient, she happened to speak Vietnamese, so that was already a tough one. I couldn't really gather what the source was. I couldn't really gather a lot of information to guide my objective. So what I did is I performed every test in the knee lab from ortho.
How many of those were positive, right?
Oh, I can't even remember. The best part about that one was she thought I was treating the whole time, and she ended up coming back. So thank God, the next time I had a translator, so that helped me out a lot. But when you get a patient that doesn't speak English and you're trying to gather these tests, how can you determine if it's positive or negative? Are you looking at facial expression? Are you looking at how it feels to you? What do you do?
Yeah. That's a good example, right? I think the nice thing nowadays is most of the time there's enough telecommunication, telehealth, even with our smartphones where you can just dial up a number and get a translator. So that's the nice thing is we can do that, even just type it into Google, type in your question, right? Not efficient, so I'd say, but it becomes a very quick study in nonverbal communication, right? So I'd say you're using the opposite side becomes very helpful in those patients where I'm gonna like do the knee range and I'll like kind of shrug like, any problem? Okay, and then I'll do it on this side, like just very much, how are you with that? So I try to use that for impairment-based wise. Is it different? And they can tell, and they can be a thumbs up or a thumbs down or something. The other thing is I'll try to figure out some way to get them to understand, show me what hurts, right? Because if they can just show me that it hurts when they do something, maybe I just run with that and I start to try to make changes, right? Is it better or is it worse? And you start to do all these corrective tests. Right? I start to do all these corrective tests on there. So maybe I live a little bit more in a lot of my movement coordination stuff versus pathoanatomic where it hurts. It's like, hey, no, we're gonna figure out what makes you better versus trying to figure out what makes it hurt more. So I think it switches a little bit, but that's a tough case as well. Okay. Another question?
Yeah, another one just being, students, right? We go out to a rotation, we have that patient, and we're just trying to get that through that subjective, and then we have to quickly transition to the objective, gather our thoughts, and a lot of the time, it can be a little flustered, and then we do the objective and we try to gather our thoughts, and we have to quickly then transition into treatment. So kind of in those transitions, what do you best recommend to take a second and to gather our thoughts?
Okay. Good question. I think after subjective, based on where the body part is, a lot of times I'm going to have them change into a gown, take their shoes and socks off. Like there's something they have to do, which then gives you a minute, right, to do stuff. Or I'll be like, hey, I'm going to go grab a couple things, grab a handheld dynamometer or a goniometer, tape measure, something. So you always have that minute to step away, and it's kind of built in, right? If it's their wrist and hand, and they're sitting there without it, obviously they don't need to take much stuff off or whatever, but you can still make up an excuse to walk out. So I think even being out a long time, I still have that, maybe it's not an excuse, but I still have to go get stuff, or I still gonna have them change and I'll leave the room. So I always have time to think about things. The other thing would be is there's always a starting template that I follow, right? No matter kind of what the patient is, it's gonna be, I'm gonna start with just baseline and posture, right? So no matter if it's shoulder, knee, neck, foot, it's always gonna be, right, hey, all right, so you mentioned in our subjective, you mentioned that you had 2 out of 10 pain at rest. Go ahead, stand up, stand normal. Are you still in that 2 out of 10 pain, or is it higher or low? Let's restart our baseline, and then just take a look, right? So I know no matter who it comes in, I don't have to really think about what I'm gonna do first. I know I'm gonna ask them, do you have any pain, right? I wanna be able to start with a clean slate. It's like stepping on a scale that's not zeroed out, right? You wanna know where you're at. And then I know I'm gonna do a posture exam, and then I know I'm gonna do something functional, right? If it's something like, hey, it hurts when I pick up a box, I'm gonna say, hey, show me how you pick up a box. Hurts when I walk. Let me see you walk. So I don't really have to think about that stuff. It's more of like, hey, this is the template across. And then you kind of start to get into it. You start to learn, like, oh, I saw this was painful, I changed it, this was better. And then you get to start putting things in. You kind of just start to go with the flow. That's a good question. I think the second part was at the end of it, right? At the end of it, you've done all these tests and now you're ready to treat. Like, is there a smooth transition?
Yeah, how do I think about, what's my best TheraX? What are my 2 exercises, 1 exercise that I'm gonna give them, and may take a little time to think about what might be the best for this patient.
I think we'll save some of we have another one we're gonna do later on that's really focused in on interventions and treatment of TheraX, but I think the transition's easy because I have the same template. It's like, hey, after I do these tests, I'm probably gonna reassess, right? And my verbiage to him is, hey, we just got done pushing and prodding and testing a bunch of things. Let's recheck that bending for that box at the beginning, right? You said it was a 4 at the beginning. Just check that. Let's see where you're at before we start treating. So again, it gives you a minute to kind of gather your thoughts, reset that scale, right? Get your baseline before you treat. So, perfect. Those are good questions. Again, so if we recap, right, our objective is trying to identify our pathoanatomical diagnosis, identify a movement fault that might be driving it, then what impairment am I going to treat? Right? We're good at treating impairments, right? Yeah, thanks for hanging out with us, guys. At the teaching table with PhysioU, follow us at PhysioU.com or at all of our social media, and take care. Thanks, guys.